almost everyone takes their phone in the bathroom nowadays, right? It's like a thing. Put on a timer. Put on a 3-minute timer. I'm not even going to say 5 minutes because most people will ignore the timer, right? So 5 minutes is going to turn into 7 minutes. Put on a 3-minute timer and then get up. And if you need to come back, come back.
Hello, everyone. Welcome to HUMED. I'm Dr. David Spiro, another episode, and I'm incredibly delighted and honored to have Dr. Talar Tejerian with us. She's a board-certified general surgeon in Los Angeles who graduated summa cum laude from UCLA with a double major in psychology and neuroscience before earning her medical degree from UCSF. We are both graduates of the same medical school. We both went to San Francisco. Yay. She completed a general surgical residency at Kaiser Permanente in Los Angeles and a fellowship in minimally invasive surgery at UCLA, and then spent a decade running a large surgery practice and proctology practice, training resident surgeons and actually publishing. So she was doing what I do, which we're in academics. But what's really interesting is she founded Booty MD, BOOTYMD, a nonprofit organization dedicated to breaking the silence around common anal health problems that are widely misunderstood by both physicians and patients. And through this nonprofit, through Booty MD, she brings her surgical experience directly to the public, delivering clear, stigma-free education on a part of the body too often left out of the health conversation. Talar, it is incredibly awesome to have you on HUMED.
Thank you so much, David, for having me on. It's an honor and a privilege for me to be on this and to meet a fellow UCSF alumnus. So I'm super excited to be here, and I just want to thank you for this opportunity of talking about something that I'm like really passionate about. So thank you.
Yeah. So my partner, Molly, she found you on Instagram and she said, David, you got to look at what this woman is doing. She's really promoting something that no one's talking about. And it's really interesting. And I would love, perhaps if you're open to it, to start off with a story that you'd like to share with us.
Yeah, I would love to actually. Let me sort of tell the story about how this concept of Booty MD even got started in, for me. It was over a decade ago. I was doing general surgery, but I had a very big proctology practice too. And that was for several reasons. Number one, at the time, I was the only female general surgeon in my department, and a lot of women that are having problems in that part of the body would request a female surgeon. So I was busy from that standpoint. And there were so many patients to see. And then there were times when I had to just do clinic like toward the end of my pregnancies when I was like so large that I couldn't reach the operating table. So I would just do a lot of clinic, which what meant like I saw a lot of patients with complaints in their anal area. And I learned so much from it. And all I could tell was these patterns over and over again. And the patterns were, number one, the patients were coming to me with a referral, but the referral diagnosis was wrong. Number two, the primary care doctors or whoever was referring to my clinic often wasn't even doing an exam. And I understood why. As primary care doctors, I totally understand, especially in like big health systems where you don't have time to do an exam, whatnot, but you also need like a special table, right? And you don't have that table in your primary care clinic. So I fully got it. But they weren't getting the correct diagnosis. They weren't getting the correct exam or no exam. And then they were getting like the incorrect treatment by the time they saw me. So then they came to see me and I was like, oh, wait, no, you don't have hemorrhoids. You have a fissure, you have a fistula, you have, even cancer. I can't tell you how many times I kept seeing these things. And I was like, wow, like there's like this huge health gap, right? And I was, baseline, well, can I sort of take it back a little bit too, is that when I went to med school, I actually wanted to do health education. And that's something that I thought I was going to do. I wasn't planning on being a surgeon at all. And, at UCSF, they send us to Fresno, to do some rotations. So they sent me as my very first rotation in third year to go do surgery in Fresno, which was like super hands-on. And I just loved it. I was all in. And one day the chief resident called me out and he's like, hey, listen, forget about this health education stuff. You're a surgeon. And I was like, what? Like, I'm not a surgeon. I'm going to do like adolescent medicine or health education or something. He's like, no. He's like, listen, I've been doing this long enough. You're a surgeon. I was like, dude, you don't know what you're talking about. And then I did other rotations in third year. And then I was like, oh my God, he was right. I am a surgeon. Like this was home to me. Like surgery was home to me. Right. So as a surgeon at that moment, I saw this like thing of like, wow, this is like health education and surgery. Like these two things like married together is in this field right here. So I had this like epiphany at that moment, and at the same time, I met a local ABC News health reporter at a party. And I said, hey, listen, I just want you to know that there's this topic that no one talks about, and there's this huge healthcare disparity, and this health education needs to go out there. She's like, yeah, okay, I'm going to come record you like in your clinic. I was like, no, I didn't say record me in my clinic. I don't want to be on TV. I just want you to do the story. But she's like, no, I have to record you, but I have to record two things. Like, what are like the two things you do really well? I said, okay, cool. I do, proctology really well, and I do hernias really well. Okay, I'm going to record both. She came, she recorded both. They aired the hernia one on the first week. The other one, the anal health one, is not getting aired. I'm like, so I call her up, like, what's going on? Why aren't you airing it? She's like, oh yeah, my bosses were like, yeah, we're not gonna talk about this topic. It's not appropriate for TV. And you just kept saying the word anus and anal, like, so even though I edited it out, but like, we can't play it. I said, well, what do you want me to call it? That's what it's called. It's an anus, She's like, well, call it a rectum. Can't you say that? I said, no, I'm not going to call it a rectum. Like the anus and rectum are two different things. I can't go on and do health education incorrectly. So in either case, at that moment, I was, in a typical surgeon personality. I was like, this is not right. I can't get this health education out there, but I got to do it some way. And then that's how Booty MD was born, which is a nonprofit health education organization. So that was like about 10 years ago. I couldn't call it like, I realized at that moment about the stigma of the word anus or anal. So then I went through like all these iterations with like, everyone I knew, what can we call this thing, So that's how Booty MD came about. And yeah, that's how all the things got started.
Well, it's interesting. We have various, what we call in medicine, orifices. We have our mouth, we have our anus. But what is the reason why there is so much stigma around the word anus or anal? Like, what is it? You have to teach me something. This is what you're doing. This is what you're promoting. You have to have some insight into what the stigma is around.
And I do. Thanks for asking. I researched this and I was trying to figure it out myself. Like, what is going on? Like, why are people so uncomfortable with this word? So it turns out the word anus comes from the Latin for like a ring, right? So that's how it came about to begin with. So anus was whatever word, and anal is the adjective of the word anus. And Freud actually back in, whenever Freud was alive, what was that, the 30s or whatever it was, 40s, I could be wrong. Freud started with his stages of development, and then there was the anal stage, right? The anal retentive stage. So for decades, people associated the word anal with what Freud described as anal, which is being like uptight or like, OCD like, or, tight, like that. So, when you and I were growing up, we would use the word anal like, oh my God, he's so picky. He's just being anal about this project, or, whatever. That's how we use the word anal, right?
Or someone has a high sphincter tone.
Exactly. Yes.
That was
Yes.
sort of like a
Yes.
pejorative way of saying something. So
Correct. Like, my God, that group of surgeons are so anal. Yes, we've heard it all. So that's how we grew up with the word anal, right? And then the internet happened. And then when the internet happened and a lot of like pornography started happening on the web, what was really promoted was anal sex, right? And from then, anal sex got shortened to anal. So now people are using the word anal as a noun. So this is like one of my things, like anal sex is the term where sex is the noun and anal is the adjective, but people have shortened it where anal all of a sudden becomes a noun. So the word, the minute that you use that word, people all of a sudden associate it with sexual activity. Where you're like, no, it's not sexual activity. As like a physician, I want to use it for like the body part, right? Anal exam, anal health, anal problems, whatever it is. But no, but the collective psyche of, all of us, we can't get it out of our head that, anal just means anal sex. So
mm.
people all of a sudden put this huge category into this tiny little part of it. And that's part of like the stigma that, hopefully through Booty MD, we're trying to expand it again and be like, no, we don't have to be ashamed of words like, this person is suffering from anal cancer or whatever it is. That's not like, it doesn't automatically get associated with a sexual activity.
It's really interesting. Last night I had you had talked about primary care doctors and showing patients showing up with a misdiagnosis and patients coming in thinking they had one thing and really they have another because perhaps they weren't examined right. And last night I had a little baby that came in who was diagnosed with hemorrhoid, which is unusual for a baby, and was diagnosed with constipation, which is also unusual for a baby that's 6 months of age. And the resident examined the child and presented the patient to me because I'm in an academic pediatric ER. And I said, does the baby have hemorrhoids? What does the anus look like? And she said, I didn't look at the anus. And I said, why? And she said, I just didn't feel it was comfortable. She said, I thought maybe we could do it together, which is fine. But I think that there is, even amongst physicians, where we study every aspect of the body and anatomy. I'm sure, did you do anatomy on the 13th or 14th floor of Moffitt Hospital?
Yep.
Yeah, so we both did anatomy in the same exact
Mm-hmm.
place at UCSF. When you do anatomy, you actually study the body from head to toe, and you dissect everything. And the anus is a part of the body,
Yeah.
and if you want to be objective about it, we want to be sensitive because it's in the pelvic region, but still it's a part of the body, and we as physicians have to be somewhat objective about if someone has a diagnosis of hemorrhoids. It's really important to look at the anus and not just say, well, it seems like you have hemorrhoidal symptoms, that's probably what you have, but not even looking at the anus. What is it like? What is going on in terms of it? It feels like there's stigma even amongst primary care doctors, and this concept that you talked about, where people were sending you patients and were just completely misdiagnosing things.
I mean, there's a few things. I've thought about this a lot throughout the years, and I think it comes in different categories. Number one, like you said, in medical school, like I don't know, we spend what, like an hour talking about it. I don't even remember. I don't even remember learning anything about it. Like I remember the pelvic floor. That was like this big thing in anatomy class because it's so complex, but
So
I don't remember
complex.
anything specifically about the anus or anal health. So that I don't remember. And if you remember, like when I was in school, maybe it was the same for you. Do you remember we had specific people that were there to teach us how to do genital exams? So we did a vaginal exam and a penile testicular exam.
Mm-hmm.
We didn't do anal exam. No one taught us that, right? We had those, we had vaginal and penile. We didn't have an anal exam. So we don't get that in medical school. I don't know if it's changed now or not, but I don't remember having that. So that's one thing that gets ignored in medical school. Fine. Then think about residency, right? And unless you are learning, if you're a primary care, whatever specialty you're in, primary care, ER, GYN, gynecology, urology, it doesn't matter. If you're not rotating with a surgeon who does this all the time, you're not going to get the right training, right? So if your family practice attending is teaching you about anal health problems, but your family practice attending never learned it properly, you're going to learn the improper treatment from your attending. But they don't know that it's the improper treatment because no one came out to them and said, this is wrong, So there's the propagation of incorrect examinations, incorrect treatment being used, and it's being passed down because no one's talking about it. So that's one thing. And that's one thing that I did for primary care doctors, which was talk to them about it. And the main message is do not blame everything on hemorrhoids. I just have to say that a million times. Hemorrhoids are the scapegoat to every kind of anal complaint. It is not hemorrhoids a lot of the time. So let's stop calling everything hemorrhoids, number one. Number two, it's
By
okay
the
to
way,
say,
someone said this baby had a hemorrhoid
yeah,
last night,
yeah,
and the baby
yeah,
did have a hemorrhoid. The
yeah.
baby had normal rectal mucosa.
See?
So anyway, to that point.
Yeah, it's exactly what it is. Every kind of anal complaint equals hemorrhoids in not just everyone's mind, but in the mind of a lot of physicians too. And that's because of this knowledge gap. So that's number two. Number three, in order to do a proper anal exam, okay? And this is like, I don't care if a surgeon wants to argue with me about this. I will argue with them about it too. You need to be in prone jackknife position. What does that mean? That means that you're going to be on your belly with like your bottom up in the air. So you need a special table. You need a special setup. You need not good lights to see it, right? And you need a helping hand because you got to spread the butt cheeks and you got to look. You can't do this by yourself and you need someone to hand you your equipment. So for example, when you go to the gynecologist or when you go to the dentist, right? These are all midline structures that they're looking at. You're at the dentist, you're at the gynecologist, midline, you're on your back, they're looking at it. So why in the world would an anus, which is again a midline structure that's like hidden, right? And difficult to look at, why is it okay to do it in the left lateral position with not good lighting? This is something I feel strongly about. So you need the table, you need the equipment, you need all that, right, to do a good exam. So that's I guess the third thing. And then you need to know what you're looking at. That's the fourth thing. Because if you don't know what you're looking at, to you, a skin tag or a fistula opening or a hemorrhoid, they could all look like the same thing. Or the other one that gets missed all the time is inflammatory bowel disease mistaken as hemorrhoids, and anal cancer getting mistaken as hemorrhoids, to the point where I've seen colonoscopy reports that said the patient had a large hemorrhoid and it was really anal cancer. And we're talking about a GI doctor who is like, looking at colons all day long. So again, there's this education gap. And part of the education gap is looking at a lot of the pathology so you understand it, So what I could see potentially a mile away in an anal exam, someone who doesn't have that much experience is not going to be able to tell the difference. That's normal, right? Same thing with other parts of the body. So we can't expect every physician to know everything, but what we need to know is, number one, don't automatically blame it on hemorrhoids. Number two, don't dismiss the patient. And number three, if you're not 1,000,000% sure what the problem is, just send it to someone who knows. You know what I'm saying? I'm just saying, let's not dismiss it. And not every doctor has to know every single problem. We just have to know that there's so much that can happen in the anal area. We have to understand that we need more education on this topic.
Yeah, it's really, really interesting. So one of the cancers, and again, I'm a pediatric physician and a pediatric ER physician, so I'm less versed with adult care, but what I do know just from reading the lay media and some of the science is that colorectal cancers and colon cancer has increased over time,
Mm-hmm.
over the last 20 or 30 years. Is that correct?
Yes. Yeah.
And is that true as well in regard to anal cancer? Has the prevalence increased over time as well?
You know, anal cancer and colorectal cancer, for the most part, are very different because a majority of anal cancer is due to HPV, the human papillomavirus. So when we look at it, we mostly think of HPV, although it's not 100%. And luckily, there is a vaccine that virtually, you know, makes your chances of getting anal cancer, cervical cancer, penile cancer, whatever. Now, throat cancer, that's like a big thing from HPV, right? So luckily that can help lower the chances of getting it. But with people not vaccinating their children, that's another risk, right? So there's a lot of complicated things having to do with it. Number one, it's the fact that it's like HPV related, and if you're vaccinated, there's a good chance that you're going to be protected from it. Number two, the other thing that people don't think about is that you don't have to have anal sex, anal receptive intercourse, to have HPV in the anal area, because, it's skin to skin contact. So you don't have to have had that act. So I've seen patients that are like, I have never engaged in anal intercourse, but there you go. They have HPV in the anal area. It happens. So I think that there's a lot of differences and there's a lot of nuances, but if we can work on the vaccination standpoint, it helps like decrease the chances of that happening, basically. So like for us, like the vaccine didn't exist when we were that age, right? But do you remember Joel Palevsky? He was one of, I don't know if he was at UCSF, but he's like the foremost expert in HPV, and he's at UCSF. And I took a course there not too long ago. I don't remember when it was, but I went up to him and I was like, what's going on with the HPV vaccine? Like, you guys keep changing it, you know? It was at a time, I guess it was a long time ago, because I was going to get my first kid vaccinated. So I was like, is this the right vaccine? And he was like, yes, this is the right vaccine. Like, we got, like, this is the right amount of the different strains. So in either case, my kids are vaccinated. I actually got vaccinated from working with a lot of HPV in my clinic too, because we didn't have the vaccination when we were younger. So that is like one of the most important things with it.
Yeah, it's really interesting. We're in such a very interesting time. The rates of vaccination in children across the United States have dropped significantly, and
Mm-hmm.
there was almost like at least in Arkansas, 2 to 3% rate of non-vaccination 5 years ago, and now it's approaching 6-7%. So it's more than doubled. And in the emergency department, I'm just seeing more and more children coming in of all socioeconomic strata without vaccines. And what's interesting around this podcast is uh, vaccines have come up, and it may come up around this talk as well. And I've had a lot of people come out of the woodworks saying some things that are just completely misinformed, just complete misinformation, to the point where there's some people who actually believe that polio is made up. And
Mm-hmm.
it's just gone so extreme in terms of the misinformation out there. I have a question about uh, hemorrhoids and anal fissures, because you had
Mhm.
mentioned those two things, and they are two separate things. And
Yes. Yes.
so I'm curious what your thoughts are. We've talked on this show about processed food and the American diet and how it relates to constipation. And I'm curious if they're in from a health education and your uh, national and international expertise in anal health, is there a relationship between what we eat and anal health?
Yeah, of course. I mean, there's a relation with what we eat in every single part of our body, right? So why wouldn't it affect that in any case? So, there hemorrhoids and anal fissures are somewhat have similarities, but they're two totally different things. So, can I just go back and explain what they are? Because some
Please,
of your okay.
please.
So, hemorrhoids are basically we have these vascular anal cushions, and everyone has them. It's part of our normal anatomy. We believe it has to help with like incontinence, I mean continence, sorry. And sensation and different things like that. And when those anal cushions get larger or expand, that's what we call like swollen hemorrhoids. And you can have different types of swollen hemorrhoids. For example, you can have external hemorrhoids or internal hemorrhoids or like everything just coming out. So there's a variety that goes in the hemorrhoidal disease. And typically what happens with hemorrhoids is that and this is a real simplification, but it has to do with straining on the toilet or sitting too long on the toilet. Anything where gravity is pulling down on the anus, it's going to make blood rush down to the hemorrhoidal tissue, and then it's going to expand. Now, whether it comes out on the outside and it becomes a thrombosed external hemorrhoid, like a blood clot on the outside, those hurt like hell and it looks like a marble on the outside, or if it's like a swollen internal hemorrhoid that usually is bleeding and you might feel some pressure but not really pain because of the anatomy, or all the hemorrhoids prolapsing out. So it could be a variety of different things. So that is from, and you don't have to be constipated to get it, but you can, like, by scrolling a lot on the toilet, which is a big problem these days, hanging out there. But that's sort of like the hemorrhoidal disease. Now, there's nuances in that where collagen disorders and different things like that. So collagen and hemorrhoids and those things have to do with each other. But those are nuances. Now, for all the healthcare practitioners listening to this, please stop prescribing steroid-based ointments or creams or foams for hemorrhoidal disease. There's zero evidence for this. Where did it get started? I don't know. Who thought it would be a good idea to put steroids for this reason? It makes no logical sense, and I've looked it up. There's no data on it. And it actually makes things worse because it thins the skin. And again, people are using it for extended periods of time, and it just doesn't help. So no steroids for the anus. End of story. I mean, okay. No steroids for hemorrhoidal disease. Sorry, there are some things where you need it for. Someone's going to get a clip and be like, she said this. Um, so that's hemorrhoids. Now, fissure is a cut in the anal area, and that typically happens from anything that's stretching the anus too much. Often it's from constipation, right? And you don't have to be fully constipated. It could be just like the end of the stool, and if that end part is too large and it stretches your anus and the rest of it is loose or normal, you can still get a fissure from it. It just has to be really tiny. Or people can get it from the other direction, right? Like we were talking about, any kind of anal intercourse or anything. Basically anything stretching the anal area can give you a fissure. Now, the pathophysiology with that is that it hurts. It hurts, like people describe it like shards of glass. It hurts, it bleeds at the same time. And then your anus goes into spasm. And then as your anus is spasming, and then you're afraid to go to the bathroom because you know it's going to hurt, then you tend to be constipated because you're holding it, but it's also spasming. So the treatment for that is breaking the spasm and making sure the stool is super soft, like even almost like it can't hold the form. You just want it to not stress out the anus at all. So the treatment is to relax the anus with medication, and actually like some mental relaxation helps too, as do sitz baths. Sitz baths are sitting in warm water that actually relaxes the anal area. And then making sure no one gets constipated, and also thinking back and saying, what did I do that caused this? Let me make sure not to do it again, because it could keep happening over and over again. And the thing that people get mixed up, fissures and hemorrhoids a lot, is that with a fissure, you can get at the like in a part of it where the cut is, you can get a little skin tag, and that's like from the irritation. So often people look just from the outside, they see a little skin tag, they think it's a hemorrhoid. You touch that area, it hurts because the fissure is underneath. You can't really see it, you know. And then it gets misdiagnosed as a hemorrhoid. Steroids are given. A fissure is a cut. You're putting steroids on it. What do you think that's going to do?
Owie.
So yeah, so those are the nuances, and like understanding the different thing. And the other thing I would tell all healthcare practitioners out there is that if someone is in pain, please limit the exam that you do, because you can really traumatize someone by forcing a scope. You know, part of the exam is not just looking externally and doing an exam with a finger, but it's also putting a scope in there, similar to a speculum for a vaginal exam, but it's a little different. And if you force that in there when someone has an active fissure and they're in pain, they're scared to come and see anyone else about it. So I think it's key, again, don't force the exam. If it hurts, just don't do it, and send them to someone who can actually, like, you know, do the exam or even diagnose it without an anoscope.
Sure. So you had talked about something that piqued my attention, which is uh, sitting on the potty with on the toilet with a cell phone, and it seems like it's a very common thing. And I want to ask a question about that. Is that a problem, sitting on the potty and scrolling? Because you could scroll and get into scrolling zones and what I call scrolling rabbit holes, where you end up scrolling for 10 minutes and because it's so mindless. And what is the problem with scrolling and sitting on the potty with a cell phone?
I mean, again, it's because our bodies were not meant to sit on toilets, really, right? Like, we were, you know, squatting in the woods or wherever we were. That's how our bodies were evolved. That's how our bodies were made. And then you take that body and then you put it on a toilet for like 30 minutes a day, or sometimes like twice a day. And again, it's the gravity, it's the pressure that's pulling it down, making the blood rush down there and making the hemorrhoidal tissue swell up. So what I would say is, for, you know, almost everyone takes their phone in the bathroom nowadays, right? It's like a thing. Put on a timer. Put on a 3-minute timer. I'm not even going to say 5 minutes, because most people will ignore the timer, right? So 5 minutes is going to turn into 7 minutes. Put on a 3-minute timer and then get up. And if you need to come back, come back. Don't just sit there like waiting for something to happen. You know, it's not a sofa.
Well, you would describe, to correct me if I'm wrong, but hemorrhoidal tissue can sometimes, get put, I guess, if you could describe it again, but because you're sitting there and maybe on and off pushing for a longer period of time, that could actually increase the risk of hemorrhoidal disease. Is that what I'm inferring?
Exactly. Exactly.
Okay.
Because the blood is rushing down there, right? You have no support for that whole pelvic floor, and the blood is rushing down there, gravity is pulling it down, and that's part of the mechanism of why this happens.
Yeah. So on Booty MD, some of your more popular clips have been around foreign bodies, which I'm sure has piqued the curiosity of the public. And I actually, in the last couple months, had a pretty significant foreign body. It was a kitchen utensil and at a very strange angle, and ended up having to go to the operating room. We couldn't remove it in the emergency department. Why is it important to talk about foreign bodies in the anal area?
It's important for a few reasons. Number one, it happens more than people think. You know, like, it unless you work there, like unless you work in the emergency department, you don't know how often it happens. It happens more often than people think it happens. That's number one. Number two, it's very high risk. The risk of having any kind of damage, whether it's to the anus, to the rectum, to the colon, needing surgery, needing stomas, where the skin is brought out. I mean, where the colon is brought out to the skin, or different things like that. It's a high risk. It's a high risk activity. So that's one thing. The second thing is that, and one of the reasons why I talk about it is because it's sort of this sensational topic and it gets people to pay attention. So, what I appreciate with it is that it captures people's attention, and then the minute that I have people's attention, I could be like, yes, we're going to talk about the foreign bodies. Yes, we are going to talk about it, but let's also talk about hemorrhoids. Let's talk about fissures. Let's also talk about fiber. Let's talk about like these other things that are really important. So you sort of need the sensational information, which is all accurate, by the way. I'm not going to give any inaccurate information. It's all accurate and information, real life, evidence based. And but I also love it that it's giving a portal to talk about all the rest of the stuff that people don't know that they need to hear about, right? So again, the assumption is anal problem, hemorrhoids, but it's not. And what I love is the opportunity to bring all these other things to light to people.
Mm.
And those videos, and especially that, like the one that went viral, which I wasn't like expecting, but I'm super happy about it. It gives me the portal to talk about everything having to do with anal health, which I think is so important, because all I want to do is to talk about it enough where the stigma's broken and people are not ashamed of it anymore, and they understand it's just another part of your body and you got to keep it healthy. You got to keep it healthy.
Yeah. So this begs the question: why do people put crazy things into their anus? Like, what is the? Do you have a sense? And because the few times, because again, I see children, and I don't see adults anymore because I work in a children's ED, so it doesn't happen very commonly. But I can imagine that when something gets stuck, it's not only uncomfortable for the patient physically, but they may feel ashamed when they
Hmm.
come in. And so I'm curious what your thoughts are about why it happens, and how you approach patients when it does happen, so they feel comfortable with you in the physician-patient relationship.
I've said this a lot in the videos, which is basically like, at least for me personally, and I think a lot of other physicians and especially surgeons, like, we don't really need to, like, we don't ask why did you put it up there? You know what I'm saying? Like, what are they going to tell me? It's always the same story of like, it was an accident, this happened, that, whatever. All I need to know is, uh are you okay? Like, are you safe? Like, did you do this to yourself voluntarily, or was this involuntary, right? So that's super important. And that's with any kind of anal problem that we see in the emergency room, because I've seen some people with damage to their anus. And I was like, they're like, are you sure that this was consensual? Like, in those situations, I'm kicking everyone out of the room, and it's just like, be honest with me. Like, I'm concerned about your safety, kind of a thing. So there's that. And then, so once you determine that they're safe, it was consensual, whatever it is, which also brings up another point that I feel like sometimes when people are under the influence, and this is totally just a feeling, I haven't like looked into this deeply, but I've seen levels of damage where I'm like, there's no way you wouldn't feel extreme pain while this was happening if you were not under the influence of some sort of a substance, right? So that's another thing I would caution people is that if you're under some sort of a substance, be very careful, because if you're not feeling pain, you could really cause damage to the sphincter muscle. So that's one thing. The other thing is, again, like, a lot of people come in and they don't even say that they have something stuck up there. They'll say things like, I have abdominal pain, I'm constipated, whatever it is. And then you get an x-ray and then there it is. And you're like, why did we just waste, like, an hour waiting for this? Like, if you had just told me, like, we would have already scheduled you to get this out in the OR. So it's a matter of, um, for us, it's efficiency. And like I just said recently, like, these happen in the middle of the night typically, you know? And to be quite honest, as a surgeon, like, we're not like, we're not psychiatrists. We're not there to, like, necessarily discuss all this with them, because what our goal is, I got to get it out. I got to get it out safely, and I have to do it efficiently, because all these other things are going on. So that's my take on it. Now, I'm sure there's sexual health experts or psychiatrists or people that have a different take on it. But as a surgeon, my thing is, be honest. We're not going to judge you. We just want to figure out how to get it out. And then we need to make sure that you don't have a perforation, right? Like a hole in your colon or your rectum. And that's a big thing, because if we're able to get it out from the bottom, whether we do it in the emergency room or whether we have to do that in the operating room, depending on the level of difficulty, we often want to keep them in the hospital overnight to do abdominal exams, right? Every few hours, what we call serial abdominal exams, to make sure that they don't have a perforation. But a lot of these patients sign out against medical advice because they're embarrassed. And again, that goes against their health. Like, we're asking you to stay, and don't feel embarrassed. Like, we're doing this for your health. We need to make sure that you're okay before we discharge you home.
Right, because a perforated colon is actually, correct me if I'm wrong, but that's a life-threatening illness. I
Yeah,
mean, you could
yeah,
actually die if the colon
absolutely.
perforates
Mm-hmm.
and you get bad things spill into your peritoneal space.
100%. So what people don't realize that, yeah, people make jokes and do this about it, but people can die. People can die from this. It's not all like just, fascination and so on. It's a real health concern. That's why being careful about it, understanding the anatomy, which I talk a lot about, know the anatomy, know why we're saying that these things are dangerous, know what's going on with your body, kind of a thing.
So you had shared with me that you're not practicing, you're working on health education, which is beautiful, around an area of specialty that you're in. Tell me a little bit about what your future is. What are you trying to do with Booty MD, and where's Booty MD going to be in the next 5 or 10 years? Where would you like to see it?
Good question. um, well, I honestly, right now, I'm just so excited that people are paying attention to this topic. I'm so excited that there's an opportunity to talk about anal health education and to remove the stigma. So that's like one of the goals, right? Is to make people comfortable talking about their butthole problems. That's like number one. Number one goal. Number two is to get the education out there, not just to the public, but also to physicians. So that's another goal. We have in the works a CME that we're going to offer to physicians, again, for free, because we want it to be accessible, and at least a primer for physicians of all kinds to understand the basics of anal health care. So that's another goal, is to get it in medical education. That way the patients that are getting help get, better care, hopefully. I also have, there's an article that I wrote, actually, like, almost maybe 10 years ago, about, I don't know what that was. Uh, an article about 10 years ago in PubMed that primary care doctors or any other doctors can reference as a primer also. and blog articles and just different things like that to get the health education out there. And honestly, like, we'll have to see how things go. We have to see where, what I've learned throughout these years and throughout the journey, even for like my own health, that I don't like super want to talk about right now, but basically you never know like what tomorrow brings. You
Mm.
have no idea what's going to happen a day from now, a week from now, a year from now. You end up in places where you don't totally expect because things just happen. And some of those things are good things and some of those things are really bad things. And you just have to sort of be like, okay, what can I do with this? What can I do with this situation to make the best out of it? So at this point, what can I do to make the best out of, you know, the situation that I'm in is I can remember what I went to medical school for and what I love to do and how to fix this healthcare disparity. Where that takes Booty MD, um, I don't know, hopefully to great places. I guess we'll see.
Well, I think what you're doing is absolutely beautiful. And I think the idea of destigmatizing anal health and where anal health is right now and the stigma around it, it's there's a lot of work to do around it. And your ability to be a spokesperson for it and to speak so eloquently and use social media in a way for good. Now, you don't want to be scrolling Booty MD for more than 3 minutes on the potty.
No,
But
no, no,
yeah,
no.
I know. But
Maximum two videos. That's like even too long. What is happening, David?
it's
What
okay.
are these
It's
things?
all magical. When you get two people from UCSF on, crazy stuff happens. Crazy
This
stuff happens.
is
But
this wait, is this the first podcast these things are happening to?
yes,
Because
I have no idea why there are balloons
it
showing
would
up on the
happen with
screen.
me. I'm
It's
just
all good.
saying
It's
the
all good.
balloons were the best.
Yeah. Well, it's funny because I think our medical school, what UCSF, University of California, San Francisco, where we went to med school, it definitely attracts people who I would say are different thinkers. And I really admire the fact that you are doing something that is so good for the public and for primary care doctors, even pediatric ER physicians like myself. I explained earlier in the podcast, someone
Yeah.
misdiagnosed a baby. So I think that what is fascinating to me about this world we're in, podcasts and Instagram shorts and Facebook shorts and Apple and Spotify, is that when I give a lecture to a grand rounds or whatever, I'm affecting 100 or 200 people and I get a round of applause. Now I can put a short out or a podcast and tens of thousands or hundreds of thousands of people can actually watch it. And the power of social media for the good is tremendous. And I think the way that you approach, and for anyone listening, please follow Booty MD on Instagram. And I think that you have something that is really special in terms of your gift that you've had, which is this idea of being a health educator and realizing it for something that is so important. And now you have the physician-led background and surgeon-led background and expertise and experience to really teach from that kind of experience. And you have this beautiful art of explaining things, which I just think is somewhat magical. So
Thank you. I mean, thank you. It's, they don't teach us how to be on social media in medical school. Um, it's a learning
no,
process. You go through some like really bad, like if you look at the older ones, you're like, what is she saying? Like, what is she doing? And it was really like getting out of your zone of comfort because I was really like, really, being in front of the camera was not something I was used to. And even my kids, that would be like, oh, I have to record a video. They'd be like, what are you doing? You look ridiculous. And I'd be like, yeah, I sort of do look ridiculous. And then, but what I learned with that one video, when it went viral, I was like, what did I do differently in that video versus the other ones? And then I looked back on it and I was like, that was just me. Like that's just how I talk. That's just my personality. So I was like, oh, okay, that's all I need to do. I just need to just talk the way that I talk to normal people. So if you talk to me like, if we're having coffee together, it's the same as in the videos. So I was
Well,
like,
what it is,
okay,
what it is,
I guess
yeah.
people are responding to it.
Well, I think, we're very fortunate at the time of this recording. We have over 80,000 subscribers on HUMED. I started a year ago, and I think what I'm doing and what we did today is the word I'd like to use is authentic. I want to bring authenticity, and I'm hoping that people who are listening to this show today are hearing what you bring, which I believe is honesty and transparency and authenticity to the conversation. And I think the public and our colleagues really want that. I think people really want that level of honesty and authenticity. What do you think? Do you think that's true?
Yeah, yeah, I think so. I mean, honestly, even like something simple like, I had some videos where like a young, my friend's daughter was recording me and she had on a filter. So like you couldn't see any of my wrinkles. And then I looked back and I was like, I don't even look like a person in this, like no wonder people didn't like this. So I think the authenticity. And I also think like the other thing is, um, you know, and I know you feel this way and I feel this way. I feel like we're connected and a lot of physicians are. We understand that we're still also here to learn. So we're like, I read comments because I learn things from the comments. And then I was like, oh, this is interesting. Let me go like look this up and then like increase my knowledge based on like what I'm seeing, what people are telling me. It's the same as in clinic when people tell you things and then you have to Google it, you're like, you're doing what? Hang on, let me look it up. And then you look it up, you're like, oh, okay, let me tell you how I can help you now that I know. So it's a whole learning process. And that's all we can do. All we can do is all we can do is be authentic. All we can do is be ourselves. And, we have a job in this world to help people. That's what we signed up for, right? That's what we said. Our job is to help people, whether we help them one on one, whether we help them,
En
one to a
masse.
thousand, it doesn't matter. We're here to help. That's what we signed up for. That's why we lost our youth and we didn't sleep. That's why we have these wrinkles. But that's, and aside from helping people, it also feeds us too and brings us life, you know? It brings happiness and joy to us when people say, thank you, I learned something from you. That is just seeing those comments of people saying, thank you. This is so educational. That just like, it warms my heart so much.
Yeah.
So yeah.
Well, I use the word we're serving. We're serving something greater than us, and call it God. You can call it whatever, but I feel like you're doing a service to humanity and to so much in terms of the work that you're doing. I'd love to have you back on the show at some point. I think you're going to be a second timer, perhaps at some point in the future.
I would
But
never say no. I would never say no. And in fact, I'm going to be honest, I've never been to Arkansas. Okay.
great. Great.
So
Well, I'm
like,
going to come to LA because my son is actually at Pepperdine. I don't know if I told you, but my son is getting a PhD in child psychology at Pepperdine.
oh,
So when I come to LA, let's have coffee.
yes, definitely. I'm going to show you LA. I'm going to show you where all the Armenians are here in LA and you're going to enjoy I bet you've never had Armenian food.
I'm going to come to LA and have Armenian food.
That's
That is
right.
going to
You're going
happen.
to you're going to enjoy Armenian hospitality and it's going to be fantastic.
Well, we'll conclude this episode. So those of you that are listening, please hit subscribe on YouTube, Apple Podcast, Spotify, wherever you get your podcast information. This is another amazing episode of HUMED, Human Medicine, unveiling the human side of medicine. Talar, thank you so much for coming, and I hope you all have a great rest of the day.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.